Actually, I wanted to share about the cadaver renal transplantation, our experience, not during the COVID, but pre-COVID in the last 5, 6 years, and share with you some of the interesting cases. This is what I had discussed with Emcure Elias when he came. Anyway, I'm sure that some of these interesting cases will stimulate you, and we can share our experience. So this is the cadaver transplant which we have done at VPS Lakeshore in Cochin, and Dr. Vilesh also. Vilesh is my associate. He has joined me, and he was predominantly involved in that work, and we have published this in the Indian Journal of Transplantation. Renal transplantation is the most appropriate treatment, and a successful kidney transplantation is better than being on dialysis. The donor is a real issue. Many relatives don't come forward. Some unrelated transplants with the permission or the authorization committee is taking place. Kerala gives permission, but that number is small. So predominantly what we have to look for is a cadaver renal transplant, and this will increase the renal pool. And in Kerala, we have a network, a government approved NGO that is called Mrida Sanjeevani, or the full form is Kerala Network of Organ Sharing, and it has given a lot of initiative to deceased donor transplantation, kidney, liver, and all other organs. We present our experience on this cadaver renal transplantation. This is the number of cases from August 2012 when KNOS was started, and all these cases have been got or procured through KNOS till November 2018. We look at this on the kidneys, we had around 464 cases in Kerala till that time, but unfortunately, due to various reasons, the number of all the transplantations from the deceased donor has dropped. You can see that in the last 2 years, it has reached only 26 more, that is 490. And now we are again trying to revive that. The government policies have changed, especially brain death declaration, etc. And so this month we had 4, 5, and we also did 2. So we will focus on the kidneys. So 464 renal transplants in Kerala, and our experience is from 70 deceased donors, 66 kidneys were obtained through KNOS during this period. And the number of cases, 66, males predominant, male predominance, 52, females of 14, mean age of the donor was around 35, cold ischemia time was 280 minutes. We were registering only PRA negative cases, and periodically PRA had been done every 6 months while they were in the waiting list. So in fact, all these patients were PRA negative. PRA positive patients we did not register, and we did not consider at the time of transplantation, obviously, because BSA cannot be, PRA cannot be done at that time, in that night or in the day when the organ is obtained or procured. Age of the recipients had been between 16 to 65, and they were all on a dialysis for more than a year, 15 months approximately, plus minus 5. All recipients were otherwise evaluated for fitness for transplantation, especially cardiac fitness. Those who were unfit, they had to undergo stenting or CABG and be clear by the time the organs were offered. The etiology of chronic kidney disease was predominantly diabetes, 38, FSGS, ADPKD1, IgA7, and unidentified CKDs were the rest. Donors were less than 65. Only one was above 60. Predominantly, it was between 20 to 40 and 40 to 60. That is 20 to 60. 2 fellows were below 20 years road traffic accident. 30 kidneys were obtained in-house. I should emphasize that they did the best in-house. and second, the kidneys which were obtained from the city. The kidneys which came from outside the city limits, 11 kidneys, had a lot of delayed graft function, obviously, because of the time taken in procurement, in coming, and the coordination was not as good as an in-house. So in-house is the best in our opinion. The city-wise also, it is not all that bad. We can arrange it within an hour or two. Cross-match tests were done at that time, Amrita Hospital. Now we are doing our own cross-match. We usually prefer a fellow with a cross-match of less than 10. We don't have the time to do PP and other things. So to have a good result, we offered the kidney to people. If we usually call 3 people, whoever has got less than 10, we are giving that on that priority. There are some interesting cases. All these transplants are standard way of doing it once the organ comes. But then there are 5 interesting cases I wanted to share with you. One patient had a horseshoe kidney. Right kidney had 2 arteries and 1 vein, and left kidney had 4 arteries and 2 veins. Obviously, the left kidney was discarded. Left kidney part was discarded. So due to multiple small arteries on the left, right kidney with a part of the left kidney was implanted in one single renal recipient. That was an interesting case, and that did well. The other second interesting case is that in a hospital, in our hospital donor, a case of RTA had a blood culture positive, obviously catheter-induced infection, Klebsiella, and was sensitive to many antibiotics. So the donor was on an antibiotic to which the Klebsiella was sensitive, and for the last 3 days we continued that, and 2 weeks we gave that. Culture post-operatively blood culture was negative. Some people were very unhappy that culture positive case, why should we take? But since it was sensitive to known antibiotics and the patient had received 3 days, and because of sensitivity to many antibiotics, we continued that and we did the transplant. He also did well, and the infection did not trouble the post-operatively the recipient. Third interesting case is that one donor was 6 years, and because of the being a kid, 6 years old, the surgeon planned for an en bloc. This came from another institution in the city, and when we received, the surgeon noticed that the size of the kidney was good. So instead of going for 2 kidneys into one patient, he gave the 1 kidney each to 2 recipients. So the child was around 20 kilos or so, 6-year-old kid, but the kidneys were good according to the surgeon. And then actually the case came to us because we only had the surgeon who could do the en bloc dissection and surgery. So 2 patients got benefited. That was an interesting case. The other 4th interesting case is that the donor kidney which we received had 2 calculi in the kidney, 5 mm each. So our surgeon with a pediatric cystoscope fragmented using the laser, and then the fragments were washed away and then transplanted. Graft outcome was good. Otherwise, for a stone in a living donor, we don't consider as a fitness. They are all considered as marginal donors, and then stone is considered as a relative contraindication. But if there was a cadaver transplant and the kidney was on the table, the surgeon could do that. The 5th case was that the donor kidney was stripped cortex and accidentally cut from the surface. This was sutured with proline. We also do biopsies, then also we use proline. If you don't use proline, again, oozing and the gaping can occur. Atheromatous thrombus was there in one donor artery, for which thrombectomy was done and perfused with the HTK solution and heparin. Another point I wanted to share with you is the pre-implantation biopsy. Marginal donors could be considered. At the same time, suboptimal kidney can be avoided in being given to the recipient. We had 24 kidneys were biopsied, frozen section, and we can get this report within 1 hour. By the time post-match report comes, the biopsy report also comes. We considered only 20 and 4 were rejected because one had glomerulocystic changes, congenital, one had extensive thrombus in the glomeruli, 3 and 4 cases they had extensive fibrosis precluding from transplantation. There is a good algorithm. This is what we follow. Depends upon the glomerular changes, tubular changes, interstitial, the arterial and arterial narrowing. The pathologist will give us a grading, and we consider only up to 3 for a single transplantation. We did not consider 2 kidneys putting into one, suboptimal kidneys putting into one patient. So only 0 to 3 were considered, and fibrosis less than 20 we wanted. Fortunately, it was more than 30 into 2 patients and it was discarded. Some people consider between 20 and 30. Our policy is to go up to 20%. The glomerulosclerosis pathologist shared with us some of the slides, and I just wanted to project you the tubular atrophy and the arterial sclerosis and the intraglomerular thrombus in these discarded kidneys. There was a very surprising case. An 18-year-old male with a road traffic accident, no past medical history, creatinine on admission was 1.4. On admission of retrieval, it was 1.6. Retrieval done. Because of the suspicion of a higher creatinine in an 18-year-old boy, we did the biopsy. And surprisingly, it showed glomerular cystic changes. So we discarded the kidney. Both the kidneys were discarded. Our immunosuppression protocol was, the induction agent was basiliximab. 2 doses were given for majority of the patients. Triple immunosuppression including cyclosporine, mycophenol mofetil, and prednisolone. Cyclosporine was used because we were switching over to tacrolimus at that time. So our policy was to start them on cyclosporine. Levels could be monitored, and hyperglycemia post-transplant with PTDM and hyperglycemia could be avoided. At 3 months, once everything is settled, we switched over to tacrolimus. Now, present policy is that we don't use cyclosporine. We use tacrolimus from beginning itself. Now that we can get the test done, so TAC level, we can get it within 4 to 5 hours. So this was the protocol, standard protocol. Monitoring the levels of that, we continue. The outcome was fairly good. 55 out of 66 graft survival, patient survival. 6 patients died. PCP pneumonia was the main problem. 1 patient at 16 months had invasive aspergillosis reaching up to the brain from nasal, the region. 1 had an acute coronary syndrome post-transplant, severe refractory hypotension, and she was a 59-year-old lady, she died. 2 patients died of sepsis. Delayed graft function was noted in 12 patients. 3 patients went back on dialysis, 1 non-compliance, and 2 refractory antibody mediator rejection. Renal biopsy was done in 10 patients post-transplant, of which 3 were ATN and 7 were acute rejection, and the rejections were treated in the standard way. 2 patients had got AMR, treated with plasmapheresis and rituximab. 1 patient was back on dialysis. 4 patients had cellular rejection, responded to steroids and pulse steroid and ATG. 1 patient had a combined antibody and cellular mediator rejection, treated with steroid, rituximab, IVIG, but landed back in dialysis. Infection was another big problem in all this transplanted patient. I'm sure this is the problem everywhere in India, especially South India, highly populated, and infection is a little high. We have to anticipate early detection and aggressive treatment. This is the only way. to get them out. 12 patients had UTI. 3 had drug-resistant UTI requiring colistin antibiotic. 1 patient had invasive aspergillosis of the paranasal sinus extending to the frontal lobe, and was treated with antifungal agents, but could not be revived in spite of giving adequate doses of amphotericin. 2 patients had PCP. 1 patient had wound infection treated with antibiotics and came out. At 6 months, creatinine values were 1.4 and plus minus 0.2, and at 1 year was 1.3 plus minus 2. Now we are following up this year after 8 years of this to see how they are doing. All the patients are alive, but we are retrospectively calling them and analyzing the retrospective values and what is the current value we are just assessing, especially the marginal donors. How did they do well? Did they do well as good as the other clinically okay donors kidney? So we are just looking at this year. Prolonged cold ischemia time had more delayed graft function, especially when we got the kidney from outstation. The transportation time was more, cold ischemia time was more, so that was a real issue. So we are putting in more effort to reduce it. We gave single dose, not that we gave, only single dose Similac was received by 6 patients because of the financial issues. And since the graft was doing well, we did not push for the second dose, and the risk was also explained. But with 1 dose Similac, they have done well, and in that group, creatinine was 1.2. 6 months follow-up, no events, untoward events had been reported, especially from rejection point of view in this group. Standard treatment is 2 doses. In the 6 patients, we gave only single dose. All of these received single doses, 60 patients. So this has to be looked into whether we can reduce any, at least a cost-effective treatment. Can this be a part of it? So, dear friends, points to ponder is cadaver renal transplantation is a big challenge. It's a good option for the patients on dialysis, especially if they don't have a live-related donor. And it's a real challenge. A good coordination and a good networking like the government KNOS is very, very useful for especially patients who are on dialysis, and they are the economically poor patients. Recipient health and donor selection impacts our outcome. PRA negative, and the patients, they have to be evaluated periodically, especially from cardiac point of view, and post-operatively they have to be advised adequate care, to take adequate care to prevent infection. Pre-implantation biopsy, we had been doing it, and we could widen the many organs, many kidneys which was rejected by our colleagues because they could not do the frozen section. Because frozen section could show that they did not have any damage, much damage to the kidney, we could take 19 cases, but we also have rejected 4 cases which otherwise would have been, especially that boy who is 18 years old, both kidneys would have been put, and a suboptimal kidney being put into the recipient could have developed into CKD soon. Prolonged cold ischemia time has shown adverse effect on the graft outcome in our group, and basiliximab induction with triple immunosuppression has shown good graft outcome. I don't use much ATG because the infection rate, in our opinion, is very high in our center with ATG. But my colleagues are all using ATG, and infection has to be treated also when it comes. So coordination of the whole transplant team with KNOS support is a very important thing. And I acknowledge Dr. Vilesh's contribution and all the other team members who have made this happen. Thank you very much. This is my presentation about the cadaver kidney transplantation, a challenge to us in the challenging times, not at the time of Corona, pre-Corona. BC, before Corona.